Bismillah, alhamdulillah, wa salatu wassalamu ala rasulillah. I would like to thank the organizing and scientific committee for giving me this opportunity to be part of the first clinical oncology Qina conference 2023, and special thanks for Professor Ahmed Maqlad for this invitation. I am Ali Balbaid, consultant pediatric and CNS radiation oncologist from the Comprehensive Cancer Center, King Fahd Medical City, Riyadh. My presentation today is going to be about advances in treatment techniques for CNS tumors, mainly craniospinal irradiation. So my presentation is going to have a small introduction followed by the simulation, contouring, and lastly the planning of craniospinal irradiation. So we know that CNS tumors are so many, but in the pediatric age group, probably medulloblastoma is one of the top tumors that we see usually in our clinics, which is why it is going to be the focus of my presentation. Medulloblastoma has a tendency for CSF seeding, which is why we usually treat those patients using craniospinal irradiation. In general, for the CNS structures, usually brain cells are not dividing, and those limiting acute toxicity is very minimal, but those limitations is always for the late toxicity, which we have to keep in mind. Radiotherapy can start between 10 to 14 days post-operatively to allow for wound healing, and the general recommendation for medulloblastoma is to start radiation within 30 days post-operatively. The next part of my presentation is going to be the simulation, which is a very important step of the craniospinal radiation. If you do your simulation right, most likely your planning and the treatment delivery will go smooth. If you're not doing it right, most likely you will end up with some, I would say, hiccups during either planning or treatment. So in general, medulloblastoma affects mainly pediatric age group, and those patients, mainly those below 5, between 3 and 5, and sometimes even up to 7 years old, they require anesthesia, which actually defines whether we're going to use a supine versus a prone position. I'm going to talk about the hood position for the simulation, the arm position, shoulder position, immobilization devices, and usually for those patients, we use thermoplastic mask for the head and neck, and we use either vac lock or a cradle or customized shell, and we recommend using knee rest and ankle support just to make sure that the whole torso is actually aligned with the lasers in the room. Now, starting with the position, the prone position is probably one of the most, I would say, comfortable positions for the treating team, but uncomfortable for the patients. Why is it comfortable for the treating team? Because they can see the laser on the spine, so they can actually know that their treatment is going into the right position. If you're doing a supine technique, you cannot see the laser. You can only match it, the laser anteriorly with the head, with the sternum, umbilicus, symphysis pubis, but you wouldn't be able to see it on the spine. You have to take images, and sometimes you need to readjust patients just to make sure that the treatment is going in the correct position. Another advantage of the prone position is actually the position of the head. And most of the time, when you put the patient on the prone position, you get this natural extension of the head, which is very important in the treatment using craniospinal radiation technique. It's going to come later on my presentation. If you're putting the patient on the prone position, depending on the technique you are using, sometimes the head position can vary. For this patient, as you can see, they're using a VMAT technique, which is why just a comfortable neutral position was okay with them. But if you're doing a 3D, it's always better to raise the body on a styrofoam piece and get a natural drop of the head. So this is a natural extension. So you basically drop the head below after the styrofoam, and you get this natural extension, and you get a nice angle that's going to help you when you're planning your treatment using a posterior spine field. You have beam divergent that's not going to go through the shin, which is why we recommend having this kind of position in the supine technique. Now, his position, as I mentioned, flexion is completely unacceptable for those patients treated with craniospinal irradiation. Extension is basically the standard position. If you're using proton tomotherapy, VMAT, or IMRT, you can go with neutral position, but extension is probably the most commonly used position. Now, the arm position depends on the prone versus supine technique. If you're using a prone technique, most of the time it is recommended to drop the arms down a little bit so you can see the spine on the lateral, either MV or KV images, and you can be able to align it with your simulation images and hopefully have a better treatment delivery. If the arms are actually covering the spine, then in most of the time it's going to be a little bit challenging to do your match. Now, as I mentioned before, some different techniques can be used, or fixation that can be used for the prone position. This is a prone body shell, but you can use different. Currently there are in the market there are some prone tables that can be used for craniospinal radiotherapy. Another important part in the simulation is the shoulder position. Usually you try to pull the shoulders down away from your from the neck, and that's going to give you some space when you are actually designing your lateral cranial fields. It's going to give you some space to go down, so when you do your junction move up, you can actually still go up without exiting through the shin or the mouth, which is why we try always to pull the shoulders down as comfortably as possible. Now, in most of the time, we mainly use non-contrast CT, but some centers might prefer to do contrast for different reasons in the contouring, but it's not usually required. MR simulation is not used for the craniospinal part of the treatment, but it is important for the boost volume definition. So you either use MRI simulation or at least MRI simulation. So you register the pre and post operative MRI, and you define your volume based on that. Now, it is important that you have a spine MRI to identify the phylum terminale, the end of the thecal sac, so you can actually define the lower border of your spine field. Now, if you're using a 2D planning, which is currently rarely used, to be honest, I just mentioned these radiographic landmarks just to keep in mind. Sella torsica is centrally located. The hypothalamus is located 1 centimeter superior to the sella. Optic canal is 1 centimeter superior and 1 centimeter anterior to the hypothalamus. The pineal body is 1 centimeter posterior and 3 centimeter superior to the external acoustic meatus, and the lenses are 1 centimeter posterior to anterior eyelid and 8 millimeter posterior to line connecting lateral canthus. The next part of the presentation is the contouring, and for this part I would like to highlight this important paper. The SIOP brain tumor group consensus guidelines on craniospinal target volume delineation for high precision radiotherapy. This was published in 2018, and in this paper they actually highlighted few important parts in the contouring that needs to be kept in mind. They haven't talked about the boost volume. They only discussed the cranial CTV, the spine CTV, and the recommended PTV for both. So in general, the cranial PTV, according to this guideline, they go with either 3 to 5 millimeter, and for the spine PTV, the recommendation is 5 to 8 millimeters. I know that some centers are still not comfortable using this, and they would prefer to go with 1 centimeter for the spine, which is fine. So the PTV is basically the standard based on the center. So in the cranial CTV, they highlighted these important areas. We used not to pay a lot of attention to these foramens because we usually use lateral 3D technique, which covers the whole base of skull. But if you're doing a precise treatment with IMRT, with VMAT or proton, you keep in mind the superior orbital fissure, foramen rotundum, foramen ovale, internal auditory meatus, jugular foramen, hypoglossal canal, and of course, the one that is usually um, um, kept in mind, the cribriform plate. Cribriform plate is important because some doctors, or at least some dosimetrists, would try to shield the lenses, and with that, they might cover part of the cribriform plate. So always keep in mind that you are having all these parts in your CTV, and of course, you add a PTV, so it is will cover during treatment. Now, when you're designing the spinal CTV, you keep in mind the nerve roots along the spinal cord. And of course, at the end, you follow the phylum terminali or the thecal sac to the lower part of it, usually using a T2 weighted MRI image. According to this PSYOP guideline, they found that in one of the publications that when they imaged those patients, there was no CSF around the nerve root uh, down in the sacral area, which is why they do not actually recommend covering this anymore. So basically, you're trying to cover the CSF, which is this white uh, circle here pointed by this arrow. So it is small, but you need to follow that down, but you do not have to follow the nerve because there is no CSF following those. If you look at the CT scan, you will end up doing this CTV, you add on it on the PTV, and then of course the field border. Now, this image is taken from one of my patients, comparing it with the MRI that's been on the next screen. I was able to see the thecal sac highlighted in here, getting smaller and then disappearing. I ended up with this kind of volume, stopping probably at the top of the S2, which is why the general recommendation is to go to at least S2, S3, and making sure that you're covering all this part so your thecal sac is well covered and you don't end up with recurrences down there. The last part of my presentation is about planning. So as we all know, we have two risk categories for medulloblastoma. The average risk, they receive 23.4 gray in 13 fractions, and the high risk, they receive 36 gray in 20 fractions craniospinal irradiation. For treatment planning, as I mentioned before, 2D is rarely used. Most of my talk is going to be about the 3D conformal radiotherapy part. It gives you better dose homogeneity, but unfortunately less organ sparing, and sometimes you end up with a lot of hotspot, mainly superficially posterior to the spine. The other techniques are the IMRT and the VMAT techniques has more heterogeneous dose, but better organ sparing. And of course, the gold standard, which is the proton, which gives you the best organ sparing. Now, for the 3D conformal radiotherapy, the technique we're going to use today is the supine technique. As I mentioned before, head extended at least 11 degrees. We put arms by side. We use thermoplastic mask for the head. In the CT scan, it is recommended to use a 3mm slices for the head and 5mm slices for the spine. Some centers, especially if they're using, standard 3D techniques, they might use 5mm for the head and 10mm for the spine, but the general recommendation is using this slice thickness. Scan from the top of the head down to mid thighs, making sure that you're contouring, of course, the ovaries, the testicles, just to document the dose there. It might not be that significant. It's always very low, but keep in mind to document that dose. We use two lateral parallel opposed fields for the head and 1 to 2 posterior spinal fields. We can use an extended SSD up to 130 centimeters to encompass the entire spinal field if possible. But if the field is larger than 50 centimeters, we end up usually with two fields using 100 centimeter SSD and a junction in the middle. Now, why can we use 130 centimeter SSD? Because the BDD is not that significantly different, so we do not expect a lot of increase in the anterior organs comparing 100 and 130 centimeter SSD. Next is to define the cranial field. Now, to start defining the cranial field, we first have to decide where to put our isocenter. And there are three main positions for the isocenter. We either position it in the outer canthus, and it has its own advantage. And also, we can put it in the junction with the spine field using a half beam block technique, or we used an isocenter at the midbrain. Of course, in overall, we always try to do collimator rotation, and this rotation is based on the field length of the spine field and also the SSD. These images actually shows the difference between the three isocenter locations. In this one on the right, we use a half beam block, and we put the isocenter in the at the junction with the upper border of the spine field. This technique has advantage is that we do not need to do a couch rotation, so the treatment will be in the same position and the couch will be in the same position. The other position is to put the isocenter at the outer canthus, and this technique gives you less or no beam divergence to the other eye and the other lens from each lateral field compared to the isocenter in the middle, where you get this beam divergence. So even if you are shielding one lens with beam divergence, you're going to be treating the other lens, which is why this technique might have some disadvantage, but at the end, it's not that of a big difference. Now, we defined our isocenter and we designed our field. If you look at this, you can see, as we mentioned, you need to do a collimator rotation. Why? Because you have this diversion of the spine field. So if you are trying to do this, you will end up with high dose region represented by this triangle, which is not going to be good. And also you'll have a low dose region in here. Usually it is not recommended to use this. So the general recommendation is to do collimator rotation based on the equation I just mentioned in the previous slides. And then you can match your posterior spine field with it. It's going to look beautiful, and the dose is going to be nice and homogeneous on the junction with no high or low dose regions. Now, the other part of the match is if you're using either a midbrain or anterior canthus isocenter. As you can see, you will have beam diversion going through the upper spine field. And to do this match, you have to do couch rotation. As I mentioned, if you're using half beam block, you do not need to do couch rotation because your field is going to end up in here. So you can have the couch still on the same angle at 0. But if you're using an isocenter in the midbrain, then in most of the time you need to do, or in all of the time, you need to do this couch rotation to do a match between the beam diversion of the cranial field and the upper border of the spinal field. And of course, if you go to the opposite lateral field, again, you're going to have to move the couch to the other direction. So this is how it looks. So you do a couch rotation and you can actually treat the lateral fields having these inferior borders of both lateral fields matching, so you can actually match the spinal field on it. And how we calculate the couch angle, this is the equation, so we can do the couch angle calculation. Now, the spinal field, after we define the upper cranial field, the upper spinal field, we end up with the lower spinal field. We usually use a third isocenter to treat the lower spine field, and we usually have a junction between the upper and lower spine field. And this junction, usually it is recommended to have it below the spinal cord, and you would like to have the high dose region anterior to the area where the spinal cord and the nerve roots are. So you have this high dose region in the vertebral body rather than at the area of the spinal cord. You might have a small a low dose region in here at your CTV, but this is better than having a high dose region and damaging either the spinal cord or the nerves below it. So junction, as we mentioned, that you need to move the junction. You're treating with 36 gray, so you need to move all junctions to reduce the possibility of hot and cold spots. Asymmetric fields are used to further the junction sometimes, and this junction has to be moved in every 9 gray or each 5 fractions. So you'll end up having 4 plans, and the junction moves usually superiorly, so that's why you start your field design for the cranium just above the shoulders, and then you move 1 centimeter with each junction superiorly, which is that, and that would be like 3 centimeter. If you use an SAD setup for the spine field, you can use a gantry rotation on the inferior spine field to match the divergence of the superior spine field. Okay, and this should give you a better match, but in general, variable SSD. So how we do that? We put the isocenter on the lower spinal field border, and we use half beam block, and we treat the rest of the spine using a half beam block. Another disadvantage of this is it gives you more beam diversion low, so the ovaries might have a higher dose. Testicles are not that close, but this, just keep in mind the beam diversion of the spine field. The technique that helped a lot, and it's not actually a new technique, it's been there for many years now, which is the field in field. Why are we using this? Because in Eclipse, planning is cumbersome, and if imaging is required, each isocenter must be in its own plan. And with junctions, you can end up with more than 10 plans, which is why field in field can reduce the number of plans by including the junction change during each fraction instead of after a set of fractions, which is like 5 fractions. And we can use the MLC to define the subfields, which are merged together to create a field in field. So basically what we do is we have all the junction moves in each fraction using only MLC. So we open one MLC and close one MLC at the junction between the cranium and the spinal field. And with that, we basically can actually have a field in field plan that can actually save time, and we do not have to worry about the junction move for the whole treatment. So as I mentioned, how we do that is basically we move MLCs. So if you would like to move the cranial field up, you basically add an MLC down, and you open an MLC from here just to move the junction, and that's going to happen during the treatment. So you don't have to worry about moving the junction after each 5 fractions. So just a few other comments regarding 3D conformal radiotherapy. Not as much focus on isocenter at the level of the outer canthus. Yes, it can spare the lenses, but cataract surgery is very easy nowadays. And unfortunately, this technique can actually shield cancer cells. So that's why we try not to focus on it. And couch attenuation, some centers are using board insertion that has a lot of attenuation, so you have to keep that in mind for long patients. Other comments: the inferior border of the inferior supine field. The beam diversion, as I mentioned, can go into the ovaries, so you have to keep that in mind. And all field sizes involved in junction change must be a whole if you're using field-in-field technique, because you're using MLC, and the MLCs are either 1 centimeter or half centimeter. So just keep in mind to have that number in mind. So the next part of my presentation is going to be for the different advanced technique like IMRT, VMAT, tomotherapy, proton. For IMRT in the cranium, some recommended 7 fields, some recommended more fields, just to get good dose distribution. So in this technique, we're using 7 fields using these angles, and in the spine we're using 3 fields, one posterior 180 degrees and 2 obliques 145 and 215 degrees posteriorly. You can see this is how the dose wash looks like from 0 to the maximum dose, and most of the lateral part of the body is avoided, and dose is distributed in the middle like this. Looking at the prescription dose, you can see how you end up with this nice dose coverage on your PTV. Looking at the sagittal view, the dose is very beautiful with no hot areas. Below the skin on the back, and those anteriorly can spare a lot of heart with this technique. Another technique, which is the VMAT, it decreases the dose to the anterior structures, just like IMRT. It increases integral dose. Unfortunately, even compared to IMRT, it is more convenient because you don't have to move the gantry. You just use arcs to deliver the treatment, and there is of course no junction shift, and there is no couch rotation or collimator rotation. Usually use 2 to 3 isocenters with few arcs at each iso center. So this is how it looks like from the cranial part and also on the spine. So you end up with 2 or 3 isocenters based on how long the patient is, and of course you will have a very nice dose. You can see in here, this is the dose color wash from 0 to the maximum prescription point, and this is how it looks like, even slightly more conformal than IMRT, and it looks very beautiful if you look at the sagittal view with no very high dose regions on the back. Tomotherapy, it's a helical treatment, conformal delivery. It has some advantages and disadvantages compared to VMAT. The dose distribution is almost the same, so we're not going to actually discuss it. This is how you can see the difference between 3D and Tomo or VMAT. You can see that you end up with, in 3D, you end up with very high dose region, and sometimes it's up to 115 or even higher percent. But if you're using VMAT or IMRT, advanced techniques, you don't have that high dose region, and your plan would look beautiful. Again, if you're using 3D for the cranium, you cannot actually spare the lenses. If you're using VMAT, you can actually drop the dose a little bit in there, but on the expenses of having more dose wash on the areas that is usually avoided using 3D. What about proton therapy? It has a limitation because you cannot access it everywhere. It's very expensive. It obviously decreases side effects, and of course, because it can actually avoid normal structures, and also decreases the integral dose, and on the same time, risk of second malignancy in the future. So this is how it looks like if we look at the back beak of the proton therapy compared to the PDD of the photon. You can see that in the photon you start with high dosage in the middle and in the beginning, and then this dose drops with time. But in proton you have low dosage in the middle or at the beginning, and then in the middle you end up with high dose, and then the dose stops completely. So I'd like to thank you for giving me this opportunity again, and I hope that this presentation was useful to all of you.